That investigation revealed that there are certain barriers that Kansas women of reproductive age have to deal with. Number one is, of course, distance, and that's where the desert idea comes from. But then also lack of health insurance and lack of providers.
A 2023 annual report by the March of Dimes indicates low grade for Kansas in care before, during, and after birth. The report found that 45.7% of Kansas counties are defined as maternity care deserts, indicating a lack of obstetric providers and lack of hospitals and birth centers with obstetric care. On today's Sound Living, improving access to maternal care across the state. Sound Living is a weekly public affairs program produced by Research and Extension at Kansas State University. I'm Jeff Wichman. Elaine Johannes, Kansas Health Foundation's Distinguished Professor of Community Health at Kansas State University, says maternal care is not just a women's issue. She says it affects men that are part of families and our communities too, and that if there's a death in a small town, it affects the whole community. Elaine, it seems like there are just more and more opportunities to serve on committees, and in the position that you're in, you get a lot of requests, and the latest one is based around maternity.
Yes. First off, let me admit I'm not of birth age anymore, Jeff. I'm kind of beyond that age. So when I was invited by the Department of Health and Environment, the Bureau of Family Health, to be part of the state's Maternal Health Innovation Committee, it is a very wonderful, diverse group of people, not only women, but men and all kinds of different people living in different parts of the state who are looking at our maternal mortality issues. Kansas has maternal health deserts. That's a term that the federal government, through Health and Human Services, HRSA, which is funding this initiative, has designated counties in this state and other states as deserts for birthing mothers that don't have access to care. And let me give a personal story. I remember during my birth years, the miscarriage I had was terrifying. I was afraid, I didn't understand, but I was close to health care. So that was helpful. And I had a provider who I knew. And since then, I've become a mom and a child. But thinking about what that personal experience meant to me, and then knowing what Kansans are having to deal with now who live away from health care and don't have access. So, Jeff, I became more aware of maternal health through that personal experience. And then I became a safe sleep instructor in 2019. And that was a real call for, okay, why do we have infant mortality? And so I learned that. But as I became more aware of infant mortality, I started to watch our own workforce here in Extension and became aware of the women who are of birth age, who are in Extension, who live in remote parts of the state. And so that's probably why I'm attuned a little bit more now to maternal health and maternal mortality. The other thing that not only this current committee are looking at, but previous ones are aware that not everybody understands how pregnancy goes. So education and awareness. Some people don't really understand some of the risks related to pregnancy, hypertension, if the woman has other chronic conditions, obesity, diabetes. Back in 2016, Jeff, there was another federal initiative that established the Maternal Mortality Review Committee. And that review committee looked at deaths in this state while women were pregnant or during the birth process or even a year after. And that early committee, which is still functioning now, looked at 105 deaths in the state between 2016 and 2020 that were related to pregnancy. And that investigation revealed that there are certain barriers that Kansas women of reproductive age have to deal with. Number one is, of course, distance, and that's where the desert idea comes from. But then also lack of health insurance and lack of providers. I think we understand that being a healthcare provider is a challenging career. It's very rewarding, but it is a challenging career. And there are some projections being done right now looking at where those maternal health deserts are in the state related to lack of access to a hospital, a clinic. But then now we look at providers like the OBGYN. There are some hot spots in the state that right now lack providers, and those are primarily in rural frontier. There are some urban areas that don't have enough providers. But, Jeff, when we look at what's projected in 2030, there's only like 4 counties in the whole state that have adequate providers. And yes, that's your Sedgwick County and that's your Wyandotte and Johnson. But those providers, if that's really only who's in the state, can you imagine their workload? So that creates a barrier for the mother, the family who lives in an urban area, because they may have to wait to see, because imagine your provider is seeing people from all over the state.
It's more difficult because the committee can come up with ideas, but as you say, you have to have someone who can put these into practice. So what are maybe some of the more practical things that we can do just right off the bat?
Yes. I think first step is what I did. I became aware, just because I'm not of birth age anymore, it doesn't mean that I shouldn't care. I shouldn't care about the younger women, the younger households in my community. So it's a workforce issue. So be aware, and as an employer, be aware that health insurance is important because that means you're keeping a healthy workforce, a younger workforce per se, and you're keeping them engaged, and they want to locate in your community because they know, okay, we want to start a family, we have a household here. Where do I go for health care when we start having our first child or others? So be aware, be an advocate for health care and health insurance that actually covers not only the basics, but, some of these complicated health issues like a complicated pregnancy. And then also be aware that we are so appreciative of telehealth, right? So the pandemic has taught us that telehealth can actually happen. And if you've got enough broadband in your community, maybe people have access to it. But that doesn't mean it's personal. So it's that personal asking a pregnant mom that maybe you notice is having some issues. Maybe she's bleeding and not necessarily seeking care. Well, that could be a rupture of sorts. There are some symptoms, actually, if we work with people in our community who are pregnant and we're a little bit worried. Some of the symptoms that we should be aware of include breathing issues, cardiovascular, some hypertension. We know that some women are susceptible to hypertension during pregnancy. Changes in vision, swelling, which is really unusual, some nausea, severe belly aches and pains, overwhelming exhaustion. And we can't forget that being pregnant is a physiological state, and it can have some bearing on our mental health. So if we talk with a friend, a pregnant person, and we find that they are anxious and depressed, we need to encourage them to get help and be along with them. Actually, maybe go with them, especially if they have to drive 60 miles to get a checkup. So this committee, Jeff, that I'm on, the Department of Health and Environment Committee, is not only looking at during pregnancy, but the state of perinatal, which is a year out, a year after delivery, and some of those mental health and anxiety and depression issues we're looking at too, because it is something that women need to be aware of, that transitioning from pregnancy to post-pregnancy is stressful, but there are some physiological changes that bodies go through. And so this committee and the previous one, the review committee that looked at maternal death rates and reviews, are aware that within that window of a year after the delivery is still a risky one.
It's difficult because we often think that this has to be through a health center or it has to be through a hospital. Are there maybe some other lower options that may pop up here and there across the state?
Yes. I'm so glad you mentioned that, because one of the other things that the KDHE initiative is looking at, and others around it, the policies that allow those axillary providers like a doula, a community health worker, those kinds of individuals who are trained, who are certified, who are professionals, but they work alongside a healthcare team. They aren't just practicing alone. They're part of a hospital system, a clinic system, some rural health centers. The Kansas Doula Association is really an advocate for health for everyone, but mostly, again, for pregnant or soon-to-be pregnant moms. And the delivery that they help with can be done out in communities because they know what they're doing. but that requires some policy changes, some looking at, are we educating doulas? Are we able to put them in places where they can actually be paid for their work? And the quality of life of people in rural frontier areas are also of interest to a doula or interest to a community health worker. So the committee is looking at access for workforce in those axillary professions. There are some proposals that our state has suggested and actually sent to the federal government to expand reimbursements for Medicaid services. That expansion would help pay for things, pay for community health workers, pay for more of the connection with care. And let me say a word about these kinds of providers. They are actually supervised and part of a healthcare team. I am learning more about these teams thanks to our connection to the University of Kansas Health System, who have care collaboratives across the state. And those care collaboratives are conveners of different providers, different parts of the healthcare system, and they welcome those other providers like a doula, community health worker. Here at K-State, we just graduated our first class of physician assistants. That's another contributor to dealing with some of these maternal care deserts and just the general shortage of healthcare providers in the state. K-State is part of that. Extension, definitely. We have so many of our agents who are on local committees looking at how does the hospital thrive in changing demands? What kind of providers can we locate here in the community? How do we do telehealth? Those are things that not only Extension's involved with, but then the other businesses in a community.
Is this something that can also be shared with other states facing these same problems?
Yes. Kansas is not alone. You're absolutely right. And an indication of that is the amount of these maternal innovation grants that HRSA has awarded to rural states like ours. There is a concern with access to care across many rural and frontier states, and then the cost of that care. You can imagine if you don't have a provider close and then they have to have all this other equipment and welcome mothers from all over different counties, different parts of the state. And then they have to keep the mother there in a facility to check her and make sure she's doing okay. It can be expensive. So rural states, Midwest states that have challenge to recruit and keep healthcare providers, yes. Other states are along with us. Again, looking at the projections with OBGYNs in the state, 2030 is going to, again, projected to not have very many, not only in rural, but in some of these semi-urban metro areas too. And so how can we all work together to encourage people to go into the field of obstetrics and maternal care? But then more importantly, how do we keep them? And that's an important question that I think Kansas and other states are working on.
Important work, and important for Extension as well, because as you say, we have that presence in all of these counties and will help in whatever way we can.
Mm-hmm. Yes. And I want to say something about this is not just a woman's issue. The men that are part of families, the men that are part of communities. I remember David Key, who's one of our wonderful extension directors up in the Northeast, who told me, Elaine, if there's a death in a small town, it's that whole town. It affects the whole community. Thus, if a mother dies in childbirth or after, it affects not only the men in her life, but the whole community. It's a ripple effect. And so we are all needing to be aware. Pregnancy is wonderful. Childbirth is great. But we need to be aware that it has a ripple effect. One death affects the whole community. And so I do think we can all contribute towards being watchful and helpful with pregnant moms, their families, and then looking at our access points, helping the providers, and thinking about some of those policy changes that may include more Medicaid payments and also more providers, the doulas, community health workers.
That's Elaine Johannes, the Kansas Health Foundation's Distinguished Professor of Community Health at Kansas State University, with information on efforts to improve access to maternal care across Kansas. Sound Living is a weekly public affairs program produced by Research and Extension at Kansas State University. I'm Jeff Wichman, and this is the K-State Radio Network.